I'm going to give you a real clinical scenario that needed to be intubated and the steps we made to intubate that patient. A 68-year-old gentleman with severe bilateral pneumonia and acute hypoxic respiratory failure. This patient was on the floor. Initially, he was DNR denied, do not resuscitate, do not intubate. But later during his hospitalization, he changed his mind and he agreed to be intubated as he was getting very hypoxic despite maximum amount of oxygen provided through CPAP. So we decided to proceed with intubation. So the first step, is there any contraindication to intubate this gentleman? The patient is okay to be intubated. Himself said he wants to be intubated. There is no clear contraindication to proceed with intubation to me. Second, I immediately thought, should I intubate him in his room on the floor, or do I have time to move him to ICU where the setup is much more controlled and the nurses there much more experienced, or not? In this case, we decided to proceed and transfer him to ICU and intubate him down there. Now, if I decide to intubate him in his room, I would have called what we call respiratory rapid response. This is a code in our facility that when I call it, I get all the tools, all the help I need to intubate this patient as quickly as possible. So check your facility. Each facility has a code to activate for endotracheal intubation. Remember, most of inpatient intubations are urgent/emergent and need to get it done as quickly as possible. So it's very important you find the codes your facility using to activate endotracheal intubation. Now, if the patient is crashing, don't hesitate to push that code blue button. Now the patient is down in ICU. He was already on CPAP, requiring 12 centimeter H2O and 100% FiO2. So he was already on the maximum amount of oxygen. He was still awake and breathing, so I kept him on that. Next, make sure he's in a monitor. The patient in ICU was already automatically, we placed them on a monitor. But let's say we kept him on the floor. Make sure immediately to put him on the monitor. You monitor his oxygen saturation, very important, his heart rate, rhythm, blood pressure. From now on, you need to keep your eye on the monitor, or at least assign someone to update you on any changes on the monitor, specifically oxygen saturation. Now I try to maximize his oxygenation as high as possible, the pre-intubation oxygenation. Remember, you try to get them to 100% if possible, but like this gentleman, he was barely setting 80%. So that's the highest we could achieve. Pre-intubation oxygenation is relative. Some you can reach 100%, do it, and some you barely reach 80%. So it's really relative, depends on the clinical situation. I immediately, as soon as we arrived to ICU, I asked them to get the patient weight. I immediately told them what's my preferred agent for sedation induction and for paralytics. Now, it's very important that you familiarize yourself what's your facility RSI kit contains. Now, RSI kit, it's a kit that has the medication required for rapid sequence intubation, the sedatives and paralytics. In my institution, usually they have in the RSI kit etomidate, rocuronium, and succinylcholine. So it's very important to know what your RSI kit contains so you pick a medication from that kit. Now, why do we have that kit? Because otherwise I have to tell them, hey, I need, let's say, etomidate. Then they have to obtain it from the local Pyxis, which is the electronic pharmacy they have in the unit, or they have to get it from the pharmacy, and they may take a few more minutes. But the kit is right there, they open it, the medication is in there. So it's very important you know what the RSI kit contains, so you pick a medication that's already in the RSI kit. Now, if you decide to pick something else not in the kit, make sure you order it as soon as possible and make sure they get it for you as quickly as possible. So make sure you ask your pharmacist about your institution RSI kit and what medication it contains. So I picked etomidate and I dose it based on his weight, and I picked rocuronium as a paralytic agent. I also dosed that based on his ideal body weight. I told the nurse to get these two medications ready for me. Also, immediately, I picked my glidoscope or laryngoscopy type. We have a glidoscope, which is a video laryngoscopy. I picked size 4 because he was a large adult, and I informed him that I need an ET tube size 4 as well. You need to provide your nurses with what medication you're gonna use and the dose, so they get them ready. You need to provide your respiratory therapist with the laryngoscopy type, the size of the blade, and the ET tube size. Remember, in large adults, we use blade size 4. In small to medium size adults, we use size 3. Now, some people decide based on the gender. I prefer really the large adult, small to medium size adults, regardless of the gender. And remember, the ET tube size, usually here I use the gender. For females, 7 to 7.5 millimeter, and for males, 8 to 8.5 millimeter. So I told them, hey, give me ET tube size 8. So they automatically understand size 8 mean 8 millimeter or the inner diameter of the ET tube. So you need to tell your respiratory therapist about that. Make sure you have an ET tube of a smaller size. Let's say you pick 8. Make sure you have 7.5 and 8.5 just in case you need it. It's right there. If you don't know what the hell is going, just confused, busy, pick 7.5 millimeter. Usually works for both genders most of the time. Meanwhile, the patient continue to be in a maximum oxygenation, 100% of I2 through the CPAP. We have not removed him off the CPAP so far. I also inform respiratory therapist to make sure the stylet is inserted in the ET tube and it's properly inserted. I have my suction yanker ready to use. I have an introducer, the bougie catheter in case I need it. And I made sure that I have all the tools needed. At this point, I move to take my position. Usually we stand at the head of behind the head of the bed, and I ask them to raise the bed a little bit. So you need to lower or raise the bed to your comfortable position. And I ask them also to drag the patient head back to me so it's easy for me to reach it. Pick your comfortable position. After that, you need to adjust the patient position. And here I'm going to take a second to talk about what we call sniffing position. There have been some confusions about what the correct sniffing position. In my description field, there is a video talking specifically about that, about the correct sniffing position. I recommend you to watch it. Just to show you quickly, the correct sniffing position. Sniffing, what sniffing? You know, if you're sniffing like a flower, you lean forward. So you see the ear hole, the ear here should be the same line to the sternal notch. So that's the correct sniffing position. So you want to put your patient in sniffing position. Now, what's the value? What's the benefit of sniffing position? It's maximize our ability to visualize the vocal cords, right? When we perform laryngoscopy. In my case, because I'm using glidoscope, and in most cases of glidoscope or video laryngoscopy, we really don't need the sniffing position. We can easily visualize these vocal cords. But you want to maximize your chance of successful intubation, go ahead and put the patient in the sniffing position. Again, that video I'm providing will show you how to do that. Now I have all the tools I need. The medications are ready. I'm in comfortable position. The patient is in good position. I did one more thing before I proceed with pushing medication. I asked them to have the ER physician to be ready if I need him to come and help me with the intubation, the backup. I always make sure there is a backup for me just in case I don't get it, or I'm having difficulty finding the vocal cord or inserting the ET tube. I have somebody that will come right away to help me with the procedure. Remember, the last thing we need is having a paralyzed patient that we are unable to intubate. Next, I looked at the monitor. The patient autosat was barely 81%. That's the best we could achieve. I told the nurse at that moment to go ahead and push the etomidate, the medication I picked. I told, go ahead and push etomidate now. Usually when they push etomidate, they flush it after. That takes around 15 to 20 seconds. By that time, usually the patient started to get sedated. Now, if the patient remain awake or inadequately sedated despite pushing the sedative, let's say in this case, I pushed etomidate 0.3 milligram per kg. What do? You give more of that medication, like you could give 0.2 milligram per kg extra of etomidate, or you can add another agent. You can add propofol, ketamine, midazolam. Just make sure the patient is adequately sedated. And the same apply for paralytics. Also, one more thing, sometimes you're intubating a patient who's completely obtunded. Let's say somebody who has a massive stroke or massive bleed. Do you really need to sedate them or paralyze them? Maybe the patient is already brain dead, right? So you need to look at these patients who are extremely obtunded, not moving at all, no gag reflex. sometimes you just go ahead and intubate them. They're not feeling anything. So pick your patient on that. Not every patient, you just by default sedation, paralytics. At that point, I told him to take him off CPAP and start bagging him. See, now I only started bagging him when I sedated him. Now, different patients are different. If you having a patient who having agonal breathing, or a cardiac arrest patient, or patient who's obtunded, not breathing, very low GCS, I start bagging them right away. I don't wait until I push sedation. When I start bagging them, I make sure I keep my eye, or as I said, assign somebody to update me on the oxygen saturation. And I keep my eye on their chest. I need to see a good chest rise. One of the complications can happen is that the patient can block his airway or her airways by their own tongues when you sedate them or when they are severely obtunded. So if the oxygen saturation start coming down, you don't see good chest rise, immediately open their mouth and open their airways and move their tongue. I usually insert, or I tell my respiratory therapist to insert an oral airway right away. Now sometimes, or some people decide to put oral airways as soon as they are sedated, and that's perfectly fine, you don't have to worry about this complication. But in case you don't see a good chest rise, the oxygen saturation dropping, make sure you open their airways and put an oral airway immediately. Now the patient is sedated. What's next? Probably a lot of you say, go ahead and chase it with paralytics. Let's push paralytics. I usually, by this time, I have made my mind how easy intubation in this patient will be. If intubation anticipated to be difficult, fat neck, abnormal anatomy, history of previous difficult intubation, I usually, before push paralytics, I grab my laryngoscopy and take a quick look and see how easy to visualize the vocal cord. And how easy to visualize the vocal cord usually has a grading system. This grading system, I think, called Cormack-Lehane system, and it's made of 4 grades. Grade 1, it's very easy to see the vocal cord and the glottis. Grade 2, you only see the posterior portion of the vocal cords and the glottis. Grade 3, you only see the epiglottis. In grade 4, you don't see the epiglottis, neither the glottis. Of course, if I have grade 1, I can easily find and see the vocal cords and the epiglottis and the glottis. Then I usually tell them at that point, go ahead and push the paralytics. If you feel the patient is going to be easy to be intubated, you may skip this awake or semi-awake look. But the semi-awake look, it's always an option to use. Remember, you perform it before pushing paralytics. Okay, now back to my patient. In my case, I pushed paralytics without a semi-awake look because I felt I'm going to be able to intubate him quickly. So I told the nurse, go ahead and push rocuronium. So see, the nurse should only push this medication when you tell them so, because it happened before and I've seen it where the nurse just, you tell them the medication and the next things, the sedatives pushed and paralytics pushed. So make it clear to them when you tell them I need etomidate and rocuronium, please don't push it until I tell you so. Now we push paralytics, then we need to insert the ET tube as soon as possible. Again, I remind them again, please update me if the oxygen saturation dropped. Now, remember, this is relative. If somebody, the pre-intubation oxygen was 100%, I tell them if it dropped less than 90%, please update me. And if somebody was the best was 80%, I tell them, hey, if it dropped below 70%, please update me. I usually give it 10%, right? If the oxygen saturation dropped, you need to terminate the procedure and start bagging the patient, trying to bring the oxygen up. Remember that very well. That's why you need to assign someone to update you, because you can easily get distracted while you're trying to find the vocal cord and insert the ET tube. Do not keep trying. Pull the laryngoscope, bag the patient again, improve the oxygenation, and then try again. Usually if I give it twice, if I try twice and I cannot find the vocal cord and insert the ET tube, I tell them call the backup right away. There is really no need to keep trying. There is really no need to keep trying if somebody else with more experience is available. Just call them and let them help you with that. Usually, who are those people? Anesthesia, ER physician, or like you have a colleague that he or she more experienced in endotracheal intubation. Back to our patient again, I was able to get a grade 1 view, vocal cords easily visualized. I inserted the ET tube without any problems. You know, the stylet was in, so I didn't have any kinks or anything. As soon as I see, you have to see the stylet going through the vocal cord. As soon as I push the stylet through the vocal cord, I ask RT to pull the stylet partially, and then I pushed more to the appropriate depth, and then pull the stylet. Now, what's the appropriate depth? I usually measure that at the central incisor. In females, I usually try to stop at 21 centimeters, and in males at 23 centimeters, and I stop there. So that's why you see these numbers on the ET tube. So at the central incisor, remember 21 in female, 21 centimeter in females, 23 in males. And then at that point, I tell RT immediately to connect the CO2 detector. And that's one of the tools that you need to have. It's the most accurate way to verify where is your ET tube. Despite the fact that I saw it going through the vocal cord, I need to make sure I did not go into the esophagus for a reason or another, right? Very important to do that. The CO2 detector, you know, from its name, it detects the CO2. So the CO2 that being washed when we exhale, right? This device will pick it up, and if there is CO2 coming out, the color will change from this color to this color, right? Now remember, esophagus may have some carbon dioxide, but very little, but it can change the color. So you need to do it at least for 5 exhalations and consistent color change. 1 color change, 2 color change, 3, at least 5 of consistent appropriate color change. Then that tells us we are almost certain it's in the trachea at that point. Now remember, somebody who is in cardiac arrest, there is no cardiac output, there is no CO2 being washed out, this CO2 detector may be useless at that point. So we listen to the chest. Listening to the chest should be performed on all patients as soon as the ET tube is inserted. And this is all before securing the ET tube, right? The CO2 detector, listening to the chest. Breath sounds has to be equal on both sides. If breath sounds are not equal, suspect right main stem intubation. So simply you pull the ET tube by 1 centimeter and listen until you get equal breath sounds. Very important you get equal breath sounds. At that point, you have appropriate color change on the CO2 detector, the capnography for 5 breaths, and then you have equal breath sounds. Only at that point, I tell them to secure the ET tube with a tube holder. And then at that point, after securing the ET tube, they will connect the patient on mechanical ventilation. And of course, don't forget about the chest x-ray. The main goal of doing chest x-ray is not confirming a tracheal position of the ET tube. Because if the ET tube in the esophagus, you still can see it on the x-ray. But it's to confirm the appropriate depth of the endotracheal tube. So the x-ray will tell you how high or low above the carina the ET tube is, or if there is a right main stem intubation. So usually 2 to 3 centimeters above the carina, and as I said, usually that around 21 centimeters on females, 23 centimeters in males. So that's the main reason of chest x-ray. Next video, I will show some x-rays on how to confirm the proper depth of endotracheal intubation, and also will show how to document the endotracheal intubation procedure. I'll see you next video.